Hi there, welcome. Sorry we're running a little bit late with this session. Really excited to be with everybody again today on our final day of Constellations. This is the third of three sessions we had planned, three discussions between experts on stimulants and safe supply and prescribing prescribing stimulants, kind of dabbling with the tension around whether this is a useful step forward towards, accessing substances where you know their content, or whether it's a more difficult thing to pursue because it's a further potentially harmful medicalisation of a response that needs to be placed back in the hands of the community. There's been some really interesting discussions. First of all, we heard from Sean Shelley and Dr. Bilabiti from South Africa and Nigeria, respectively. Then we heard from two experts from Canada on Monday, Dr. Andrea Sereda and Nazli Magsudi. And then today we're going to the Czech Republic, or Czechia, to again hear from two experts involved in the processes and practices on the ground. So first of all, I'm really happy to introduce David Peszek. He is a manager at the harm reduction facility Sananim, a psychologist and a Jungian psychotherapist. Sananim is one of the main providers of drug services in the Czech Republic. And David's been working for 18 years in the field of addictions, the real focus on harm reduction, humane drug policies, and destigmatization. Now, shortly, we are really excited to be joined by Dr. Pavel Bem, a Czech politician, former member of the Chamber of Deputies of Parliament of the Czech Republic, former mayor of the city of Prague, and currently not only a member of the National Drug Commission, but a member of the Global Commission on Drug Policy. Mr. Bem is an outspoken advocate on drug policy reform, decriminalization, human rights, and evidence-based approaches. He is also speeding towards us in a car, or speeding towards the virtual screen, and will join us in about 10 minutes. So I suggest that, since we have the benefit of your presence here, David, we kick off. Maybe you could tell us a little bit about the background of Sananim, and how we came in contact with each other to begin to talk about the protocols put in place in Czechia.
Hello, Naomi. Hello, everybody. Thank you for the opportunity to talk about this program on this marvelous festival of constellations. It's an honor for me. Czech Republic is a small country. I don't know who all is looking from around the world. So just a few words. We are in Central Europe. We have about 11 million people, and when we will talk about the most vulnerable community of people who use drugs, there are about 44,000 of these people in Czech Republic. The half of them maybe are opiate users, and half of them are crystal meth users. And among the most vulnerable community, we have people that are using what is available on the market. But because of this long tradition of crystal meth use, which is dated in the beginning of in the communist times, before the revolution, and from the early 90s, there is a really big amount of people using crystal meth, injecting crystal meth. So we are thinking for a long time of some possibilities of substitution treatment for these people.
Fantastic. That is a very useful scene setting. And just as we hoped and prayed, Mr. Pavel Bem has joined us. Please welcome Pavel Bem. Great to see you. Thank you so much for rushing to be with us today.
Hello, Naomi. Hi, David.
I've already provided some introductions, so I'll leave David to continue the conversation.
Perfect. Excellent.
Thank you.
So Pavel, thank you for arriving from the airport. It's great. You did it on time. It's also unbelievable because I know about the traffic situation in Prague in this hour. So it's great. You did come. Please, can you tell us where are you right now at the moment, and who is also joining us at the back seat of yours?
So good afternoon and welcome to everybody. I'm really happy to be quite in time, 10 minutes late, because not only traffic in Prague, but the COVID situation in Prague and all the checkings at the airport, everything is somehow becoming a little bit more difficult. And we have a friend here and a client of the contact center. I'm sitting, David, in your directorship ambulance at contact center, drop-in center in Prague. So I'm sitting in your chair, if you don't mind.
No worries.
Because I'm aware of the fact that you are not here. I don't see you here. You are probably at home, right?
Yeah.
Okay. So yes, we have Yaroslav with us today. He is not the person actually assisted with the Ritalin or methylphenidate therapy based on the crystal meth dependence, but Yaroslav is going to join us and to maybe provide us with some pieces of information. Let's see. So let's start the discussion, David. Not to lose time.
I was before you arrived, I was setting a context of the community, of people who use drugs, of the most vulnerable, and just pointing out that we have a big community of people that use crystal meth, and the tradition is 40, maybe 50 years already, and so we are probably the country which would be to talk if we are thinking about substitution therapy of people who use stimulant drugs. And I know the tradition of experimenting with substitution treatment is already going some time in Czech Republic. Can you maybe add some important history points in this way in Czech Republic?
Sure. Actually, I think, as I remember, we started to experiment, probably not in with the substitution therapy itself, but I would say preferably with assisted therapy by central stimulants, mainly methylphenidate, Ritalin, but we also were experimenting and still are experimenting with the assisted therapy by Stratera. And the first experiments off-label, certainly in the Czech Republic, it's not officially accustomed treatment for pervitin users or people addicted to methamphetamines. However, the first steps were done in late 90s. Anecdotal individual trials showing some effects, some positive effects, but also showing, let's say, the limits. And at contact center, David, we decided probably 4 or 5 years ago, or 3-4 years, something like that. And we did it in a much more systematic way. We collaborated on a setup of so-called minimum standards of methylphenidate or central stimulants assisted therapy for methamphetamine users. We also spent some time looking at the criteria of users who would match with this treatment settings. And since we knew that it will not probably be enough at all just to base the intervention only on the pharmaco-assisted treatment. So we spent also quite some time defining these so-called minimum standards. That means defining what should be part of the intervention in order to be really effective. And maybe we will come to that later, what are the standards, but the history is quite long in the Czech Republic. You also were absolutely right that the Czech Republic was not the first country to experiment with various substances which could bring some treatment effects. Well, let's say ideally similar to the effects of OSTs, opioid substitution treatment with methadone or buprenorphine or with LAM or just other opioids. Certainly, we were well aware of the fact that we hardly can expect comparable effects. But we took some experiences from UK, from Wales, and from Netherlands, and from some other countries where they started the experiments in late 80s or early 90s. And I think currently we are far away from these experiments at the beginning, and we come to the, let's say, preliminary effects later. But in short sense, I see our methylphenidate assisted therapy for methamphetamine users as very, very promising.
Maybe I will add one important historic point, and that was the crazy beginning of the COVID pandemic situation, right? It was a few years ago in the times nobody really knew what's going on or what will happen, and we were quite afraid that there will be not enough substances for people of the community to use, right? Of the not only of stimulants, but also of opioids used. So we did use this momentum quite well. Yeah, that this if one of the good things, if I can say it in this provocative way, that COVID bring to us, it's also wider possibilities of substitution treatment. And maybe you can talk or explain us how was the discussion in the Society of Addictive Diseases, this like medical tribune, and how was possible from your side to advocate that those guidelines actually happened and can be used for today practice.
David, just only a short comment. Yes, COVID pandemic and lockdowns especially have significantly affected drug scene in general in Prague as well as in the other big cities in the Czech Republic. What we have seen was first shortages of illicit substances on the black market. This was one of the reasons why we really seriously discussed how could we help in much broader perspective to that reality, because we have been that time afraid that shortages will bring new synthetic drugs on the scene, accompanied by a lot of side collateral effects, unintended negative consequences, morbidity and mortality. We also have expected that the COVID reality will substantially increase the use, even though on one side we are talking about shortages of substances on the black market. On the other hand, we were expecting really increase of use of everything, all illicit as well as illicit psychoactive substances. And this was true actually for alcohol and for sedatives, hypnotics, benzodiazepines. We have a lot of good data really showing how much COVID has affected the reality in the field of addictology in our country. But the short comment is, yes, risks involved in shortages of psychoactive substances on the black market have really pushed us to be much more open, and let's say gave us a courage to push the expert society and the decision makers and policy makers, administrators, actually the ministries, to get through. I remember some of our let's say political debates at the Ministry of Health, and my surprise, I was surprised by seeing that the very conservative administrators and decision makers, bureaucrats at the Ministry of Health, were much more open to our suggestions. So the fact is that COVID had both negative as well as also positive effects to development of methylphenidate assisted therapy in Prague.
One fact that arises is that the Society of Addictive Diseases reacted to these calls from us, from NGOs, from experts about the shortages of the substances on the market and they released guidelines that were finally approving to use methylphenidate in off-label setting, right? That you didn't have to put another diagnose to the human being that he has ADHD, and then you can give him the methylphenidate, but it was for the first time like legitimized to use methylphenidate in substitution treatment for crystal meth users. So I think that's quite a breakthrough of change minding, of change of the paradigm, how to look at this substance and the possibility to use it this way. Do you agree?
I will correct you a little bit.
Sure.
The off-label use of central stimulant assisted treatment for crystal meth users was here even 20 years ago. I did it on my own, and you know, the off-label indication is based certainly on the personal responsibility of each physician, of each psychiatrist or addictologist. What was a real difference 2 years ago was acceptance of these minimum standards of central stimulants assisted treatment for methamphetamine users by Czech Medical Association. And this is an important step for, let's say, broader legalization of this treatment intervention. And I agree with you that it was an important moment because paradoxically, we have learned that these off-label indications were quite a lot around the country, but my colleagues, psychiatrists, addictologists, prescribing, for example, methylphenidate, were silent. And we didn't share too much of information on the expert meetings or conferences because each prescribing physician was well aware of the fact that he or she might be confronted with the criticism of the Czech Medical Association and also ethical committees. And now it's much easier, actually. Now there is a standard for this intervention. It says clearly how should you do it, how should you report it, also what should be a part of the intervention except the pharmacotherapy. And I think we are on a really good road to have a robust set of data actually showing in 1 or 2 years perspective the results on a bigger number of patients or clients. It's also interesting, and I should notice probably that the first gentleman who came with this idea to prescribe central stimulants for methamphetamine users, well, Karel Hampel, once also the expert of the president of the Association of Addictive Disorders of the Czech Medical Association, so the top, let's say, professional expert chamber or body which is above I would say a best or correct or good practice in the treatment of addictive disorders. So, and he did it even at the end of the past regime in late 80s. So this gentleman, he passed away, but he deserves our memory to really, yeah, not to forget that he was a pioneer in that sense.
When we are talking about the subject, you mention a lot. We are talking a lot about the Czech Medical Society. You come from, you have a medical background, but you are also strong advocate in regarding human drug policy. And when we talk about substitution treatment, there is always this question if we are not over-medicalization the subject of substitution treatment, if the substitution treatment should be more human in terms of the rules of the treatment, of centering more on the human that needs the substitution treatment, not only about his disease as it's viewed more in the traditional medical way. So how do you think this stimulant substitution treatment, how it should be made regarding not over medicalizing this subject? We, of course, we have to cooperate with medical experts. Thanks to the Society of Addictive Diseases, to the Czech Medical Society, was actually legalized this possibility, but how to balance it, if you understand me.
And what do you mean by over-medicalization?
I mean that sometimes the traditional OST programs have very strict rules. For example,
Okay.
if you go to OST, you receive buprenorphine, and you have positive tests on crystal meth, they will ban you for 1 month, leaving you without medicament. Sometimes the dose is just not enough, etc., etc.
Okay, yes, now it's clear to me. I think when we look at substitution treatment programs in general, we see a lot of models. Some of them are very high threshold, very strict rules. Regular testing, for example. If you are tested for the illegal substance, okay, you are gone. Just you cannot continue to be assisted or treated within the program. The same might be true for the methylphenidate or central stimulants, better assisted treatment for methamphetamine users, because we also can think about various settings, and maybe they might be matched with certain individuals, and I would hesitate to say that some of them are wrong and, let's say, do not work, and some of them are right and work. But in general, I can just report what we have done here in the Prague Contact Center or Drop-In Center, where we have quite some experience with the opioid substitution treatment with OSTs. And we based our opioid substitution treatment on a low threshold model, no testing. As you said, human-oriented or human-centered treatment. The treatment is based on trust. Certainly, we are aware of the fact that from time to time, our clients are also just switching, for example, from the safe way of administration of the substance, pills, for example. Sometimes they really switch to injecting administration, and we know that this is, from the harm reduction perspective, something we wish really to prevent. But low threshold setting means that this is not anyhow the case to not continue within the treatment, and it's not the case for stopping the intervention. So the low threshold setting of OSTs in the contact center is based first on at the beginning of day-to-day contact with client, good titration of the dosage of the substance, psychosocial support, that means psychological support, but also social intervention related to housing and even let's say some vocational training, looking at the legal way how to earn some money, not to be dependent on the traditional or typical way of financial survival. It means small robberies, etc. That means involvement in a crime activities. And the same we just have introduced with the methylphenidate, Ritalin, or Concerta-assisted treatment. So we are providing our clients not only with pharmacotherapy, but also with the psychological support, and also with the social, psychosocial support. And again, no testing. Certainly, there are some rules which would really push us to interrupt, for example, the intervention. And as you, David, know, we have done it in a few cases and in a few occasions, but it's never ever resulted in cancellation of or permanent interruption of the treatment. So the provision of the care is complex, and the trust between the facility and the professionals within the facility and the client is growing and it's being cultivated. And as a result of that, in some time, we decide to allow client to be a more responsible by himself or herself. That means just we are providing her or him with the home dosages, and at the end, some of the clients are just coming once in a week, or sometimes even once in a month. And this is the perspective which allows me to really be very optimistic about the program, because what we have seen in again short comments is the dramatic reduction of the risky behavior, including the injecting practices, including the dependence on the black market. We see a very nice psychosocial stabilization of the status of the clients. We see a lot of well done and kept resocialization programs, talking about housing, for example, and talking about official employment in some cases. So we see a really quite I would say dramatic effects in a long run. And well, yes, and certainly we are confronted that if you do it too fast in some individual cases, if the home dosages of the substances are too big, certainly we are involved immediately in risk of allowing the client to come back to the black market and, for example, to sell the substance. Yes, this is from time to time, we see even that, but definitely this is not the argument for us to not trust to the program, because these are individual cases, and in general, the harm reduction is enormous.
Maybe I can add one more outcome I can see among the people that are in the treatment is that they have more control over their use in terms that crystal meth use is not destructively intervening with their everyday life. I mean, many times crystal meth use is based on many days of use, which can intervene with your work, with your ability to do your everyday life, to be a good parent, etc., etc. And what I see with the substitution treatment is this, that people have more control over their life, and they don't stop generally to use crystal meth. Let's be sincere, but I don't see that as a problem, because they have this capacity to use crystal meth in a non-destructive way, meaning they can use at Friday when they know they don't have duties to do on Saturday. They have more control over their life, and they have more positive things, and the methylphenidate is not distracting these routines. So that's something I find like a really important outcome of the whole program.
Yes, actually, I think first of all we see some of methamphetamine use among our assisted treatment therapy clients, but not in all. First, secondly, we, as you said, we see certainly in many cases the need to reward themselves for, let's say, abstaining for a week or 2 weeks or even a month. So rewarding means allowing them to abuse or to misuse the black market crystal meth. However, as you said, in quite, and again I said it in quotations, controlled way, not an excessive use, with harm reduction effects, for example, not really injecting, in some cases also from time to time injecting, but we see different ways of administration of the substance, and one of the let's say Czech invention how to safely use crystal meth was introduction of the capsules through which you could administrate the substance in a safe way with just elimination of the risky injection, and this is the Czech patent. And we distribute the formula for that. So we see all kinds of harm minimization and let's say much safer behavior control among our clients. David, we do have also questions over there and comments. There's a comment, yes, about the trust between the facility and the client. We just insist really on that. This is crucially important, and we permanently reflect that during the psychosocial interventions, and even when we provide clients with a substance. There is also a question on the gender sensitivity. Well, yes, no actually stigmas even for trans or binary people. We don't see them too much actually in the assisted therapy. We see quite a lot of them within the other services of low threshold center. There are no stigmas or limits in accessing our prescriptions for anybody. The question is good matching or just the decision and contract with the client on methylphenidate assisted therapy. And the other from Colleen question, if we are aware of prescription options in other jurisdictions that better mimic the effects of stimulants.
I think Colleen is asking for the possibility of
Exactly.
another substances to use as dexamphetamine or even methamphetamine in the substitution treatment. And I know this is a subject that is important for you. So let's spend a few words on this subject.
Short comment, actually. When we were putting together these best practice or minimum standards provisions for pharmaco-assisted therapy for crystal meth users, we didn't speak only about methylphenidate, but also about other central stimulants, and I already mentioned atomoxetine, Strattera, and you now mentioned dexamphetamine, and we tried to put through the bureaucracy also the so-called legal use of methamphetamine, but that time we were not successful. But I personally believe that this is probably part of the future, as we see in OSTs limits of methadone or buprenorphine for certain clients, and we see a very good effects of HATs, heroin-assisted treatment programs. So I think at the end we might end also a couple of years later with methamphetamine-assisted treatment and intervention for crystal meth users. And my guess is that we probably might have, in some cases, more positive effects. Certainly, there are other risks involved in, as far as the misuse is concerned, etc. But I think we should be clever enough to experiment even with methamphetamine. And I know that there are some good papers, scientific papers, already testing methamphetamine for assisted treatment with quite some effects.
We have one more question regarding monitoring side effects of the substitution treatment, as anxiety or heart diseases, complications regarding hypertension, etc. Do we need to monitor these circumstances in the substitution treatment, or do we know that long-term crystal meth users are that methylphenidate is just not that risky at all than crystal meth?
Yeah, well, this is a good comment. But in reality, again, we have to be open, and we certainly are aware of the potential negative effects and risks involved. So we clearly set up a list of contraindications. Even though from the harm reduction perspective, as you just noticed, David, there are no contraindications, but for the responsibility of the physician who undertakes actually a certain personal risk or responsibility in prescribing these substances of label, even though under the guarantee of Czech Medical Association. I think yes, clear list of contraindication. We can share that just via correspondence. We have some nice presentations. Again, we can provide it for free for everybody just involved now in the debate, or who is just interested in sharing some practices and experiences with us. We are just open to share anything with anybody. But for example, acute psychotic states is one of these contraindication. Endocarditis influenced or caused by the crystal meth use in last half a year was another contraindication for us, really, to avoid the risks of cardiac diseases, etc. So there are like 6 or 7 or some neurological contraindication, some clearly stated contraindications, but as you said, from harm reduction perspective, it's a nonsense, because it's really much safe to use Ritalin instead of crystal meth. It's much safer to use it just via pills administration than via injecting administration, even though you have acute form of endocarditis, or even though you have just manifested toxic psychosis. So in fact, from the harm reduction perspective, there is almost zero contraindication. But we do not want to endanger the program from the early beginning. So in fact, when I use the term low threshold central stimulants assisted therapy for crystal meth users, there is some threshold, and the contraindications are part of this threshold for now time being.
Maybe we are going to the end soon. I will ask one more question about the values. There is sometimes the debate between the harm reduction community and the community of abstinence orientated treatment. If abstinence should be some important goal in the substitution treatment, or even the harm reduction, if we should be aware of the human rights, of not pushing people toward treatment, or how to find proper motivation and recommendation to change in lives of the people. And we we both work in low threshold context for very, very long time, and we see a lot of very vulnerable people that are using substances just to kill for some time a strong inner pain. They suffer, maybe not somatic, but not only somatic, but also like of the soul. And you as a doctor are in a way obliged to help the people from suffering of pain. So what is your side on this debate, or how do you look at it?
Yeah, actually, this is a nice question because
It's a provocative one.
because from the first glance, we could think that the harm reduction services are just extremely human but pragmatic ones, and they just are wish to minimize, to reduce the all health, social, and economical risks involved in use of psychoactive substances. Well, and we might think that the spirituality and sort of existential thoughts are so far away from harm reduction, but this is not true, at least not for myself. And I think Yaroslav is a good example, so we can welcome Yaroslav here, who spent more than, yes, hello?
I'm glad to see you.
Yaroslav, you spent 45 years on hard drugs, using everything, using crystal meth and using opioids and heroin and all the stuff available in the former communist Czechoslovakia, but also later on capitalistic Czech Republic. And well, involved certainly in quite risky behavior. But at the end, if I may say that, on behalf of you, decided in a very difficult health and social condition, decided to take part in substitution and assisted treatment. And well, and after a couple of years, I don't know, 3-4 years of that support, Yaroslav is coming and saying, well, I maybe need to reduce the amount of substances, the medicine used by the assisted or substituted treatment. And Yaroslav is thinking about drug-free life. So, well, I think this is definitely, this is not, the abstinence is not a forbidden word for us. But the question is how we use this word and how we use the semantics related to abstinence. And my answer is, it's not a product of my brain, my wish. I could have a wish that Yaroslav is just going to switch to drug-free world. But I'm also well aware of the fact that he has gone through his life through such an emotional trauma, through physical and emotional and psychological abuse. And then his emotional brain, based on a neuroreceptor system, and I'm talking now about dopamine and endorphin needs and serotonin needs, are simply, I don't know if permanently affected by the reality of his childhood and even perinatal time, but definitely in a long-term setting. So these abstinence-oriented thoughts should be a part of the psychosocial intervention in terms of dialogue, in terms of debate, but not in terms of coercion, coming from us as professionals. So once it's come from Yaroslav brain, from Yaroslav thought, it's becoming the message that we can start to think and to try. But we never know if the trial, if the experiment is going to be successful. But why not? Why not to try? Am I right? It's even abstinence. Dovedeš si představit život bez drog? Yes. The question was, can you imagine that you will be drug free? Well, the answer is yes. Today, yes. So I think these are challenges of our intervention. But as I said, it must be human-centered based intervention, even very HR pragmatic. And no, abstinence is not a forbidden word, definitely not.
Perfect. Thank you. I think we are coming to the end of our time, but maybe just last question. Can you imagine that we would do substitution treatment on more substances to do crystal meth and opioid substitution treatment at the same time, as we have a lot of people using this combination among the community? So can be this in the future also a thing we can focus on?
Sure. Actually, in the Czech Republic, we have maybe 15,000 opioid users and 35,000 stimulant users, dominantly crystal meth users. And I can easily imagine to have on the substitution treatment services or the central stimulants assisted therapy or treatment services, that we can have 80% of these 50,000 people who use or dominantly inject drugs. I can easily imagine even 100%, these 50,000. And if that happened, I'm convinced that the black market with crystal meth disappears. As well as we see, once we substitute the opioid market with legal opioids, methadone, buprenorphine, diamorphine, heroin, that we see that in countries where these services, Switzerland is a just phenomenal example to us. The black market with heroin is disappearing. Maybe not in 100%, but maybe in 70, 80%. And this is enormous benefit for the society itself, for the effectivity or cost effectivity of drug policies, but it's also reducing the public violence. It's just raising public safety and security, and it's creating and generating functioning communities based on respect to individual needs. And I think this is the best way how to regulate drug market. And this has nothing to do with legalization, even though it could be a nice concept to think about, but it's just simply a legal regulation of substances. So if we significantly reduce the demand, definitely that will have the effects on the supply. And I think this is our future. at least here in the Czech Republic. And I would wish that this is also a future for other European countries and for the global drug policies around the world. And I think it will also appear once as a fundament within the international conventions, where on one side the medical care is guaranteed, especially by the 61 single convention, but at the same time the bureaucratic provisions are such enormously affecting these provisions that in fact in most of countries around the globe, these human interventions and effective interventions simply do not exist. So I think this is also a message for the, let's say, I don't know if beginning, because the reform is already going on, but the substantial drug policy reform in global sense.
Thank you for beautiful words of hope at the end of our discussion. Thanks a lot for having time to discuss. We are, I think, at the absolute end of this Constellations conference, and